Okay. Assalamu alaikum and a very good morning to everyone. I'm Dr. Ariba Rais, postgraduate trainee in Dermatology Department. I warmly welcome you all to the 21st Dermatology Clinicopathological Conference, Dr. Rutkim Fau Civil Hospital, Karachi. CPC was first started in 2022 by Civil Hospital, Karachi, where a platform was provided to discuss different clinical grey cases. Today, we are here to discuss two very interesting clinical grey cases with you all. But before that, we will start today's session with the recitation of Holy Quran.
بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر.
Okay, so now we are going to start our session. The first clinical case will be discussed by Dr. Ikta under the supervision of Dr. Neha, who is a senior registrar and consultant dermatologist. So I would like to invite Dr. Ikta and Dr. Neha to come on the stage. Presentation.
Assalamu alaikum everyone. My name is Dr. Ikta, working as postgraduate trainee in the Department of Dermatology, Civil Hospital, Karachi. Today, I'm here to share a very interesting case with you all, starting with the history. My patient is 54-year-old male, married, resident of Punjab, shopkeeper by occupation, admitted to dermatology department via OPD on 15th October 2023 with presenting complaint of blackish discoloration of fingers of right hand and fluid-filled blister on bilateral dorsum of feet for 25 days. According to the patient, he was all right 25 days back when he developed blackish discoloration of right index finger that was sudden in onset and gradually progressed to involve all the finger of right hand within the span of few days. It was associated with pain and swelling of right hand, along with fever, which was undocumented. He developed similar painful blackish discoloration on some toes of right foot and digits of left hand. Patient also had complaint of fluid-filled blister on the dorsal aspect of bilateral feet and left popliteal fossa, which were tense and took around 3 to 5 days to rupture. On further inquiry, patient had history of cough with hemoptysis 1 year back, on and off abdominal pain with diarrhea, and generalized weakness. He also had history of mouth ulcer and small joint pain of hand with no joint swelling and morning stiffness. He denied history of any color change of fingers on exposure to cold, photosensitivity, hair loss, dryness of eyes or mouth, weight loss, inability to stand from sitting position, or any urinary complaints. For these complaints, his CT angiogram was done and his right radioulnar embolectomy was done in some hospital at Punjab. Thereafter, his pain was reduced and progression of swelling along with blackish discoloration was stopped. His systemic review revealed other than the complaint already described in history of presenting complaint, rest of his systemic review was unremarkable. In past medical and surgical history, other than the recent hospitalization at Punjab for right radioulnar embolectomy, no prior admission in the hospital, and no history of any surgical procedure. He was prescribed tablet rivaroxaban 15 mg BD post-embolectomy at Punjab. In family history, he had no history of similar complaint in the family and no history of TB or any other chronic illness in the family. He had recent transfusion of 1 pint PCV at Punjab. Allergic history was not significant. In personal history was normal except that the patient is chronic smoker with history of 30 pack of cigarette per year. In socio-economic history, patient belonged to lower middle class family, lives in well-ventilated house, having no pets or birds. Moving on to examination, a middle-aged male patient of average height and build, sitting comfortably, well-oriented to time, place, and person with normal vitals. On general physical examination, only Pelar was positive, while rest of the general physical examination was unremarkable. On cutaneous examination, right hand was edematous with gangrene involving all the 5 digits of right hand. A well-defined necrotic plaque was present on the dorsal aspect of right hand, measuring around 2 by 2 centimeters. Left hand had similar gangrene which was present on the tip of index and middle finger. Right foot had gangrene involving the third toe. Multiple small intact blisters were present on the dorsal aspect of both feet. Small erosion measuring around 2 by 4 centimeter with surrounding crust present on the right popliteal fossa. Rest of the cutaneous examination was normal. Systemic examination. Peripheries of bilateral upper limb were cold. Both-sided radial and brachial arteries were feeble. Right-sided dorsalis pedis artery was feeble as compared to arteries on the left side, which were palpable with normal volume, rate, and rhythm. Rest of the arteries were palpable. No carotid or renal bruit was audible. His cardiovascular examination, respiratory examination, abdominal examination, and CNS examination all were within normal limit. To summarize my case, a 54-year-old male chronic smoker presented with 25-day history of painful blackish discoloration of fingers of right hand, associated with pain and swelling of right hand, and fluid-filled blister on the dorsum of both feet. He developed similar painful blackish discoloration of third toe of right foot and digits of left hand. His right radioulnar embolectomy was done for similar complaint at Punjab, which led to temporary resolution of the pain. He also had history of cough with hemoptysis 1 year back, on and off abdominal pain and diarrhea, mouth ulcer, and pain in small joint of hands. On examination, both-sided radial brachial arteries and right-sided dorsalis pedis artery were feeble. Gangrene of all the digits of right hand, digital tip gangrene of index and middle finger of left hand, and third toe of right foot. Multiple small fluid-filled tense blister over the dorsum of bilateral feet, and small erosion with surrounding crust over right popliteal fossa. Discuss the differential diagnosis, I would like to invite Dr. Neha on the stage.
Assalamu alaikum, everyone. So what differential diagnosis will you keep in a patient who is 54 years old, a chronic smoker, and presenting with digital gangrene along with blisters? So the differential diagnosis we keep were small to medium vessel vasculitis. This could be secondary to a connective tissue disease or could be a primary vasculitis, which may include ANCA-associated vasculitis, cryoglobulinemic vasculitis, and systemic polyarteritis nodosa. Our second differential was Burgess disease. This could be considered in a middle-aged male patient who is a smoker having a history of 30 packs of cigarettes per year along with digital gangrene. Next, we think about antiphospholipid antibody syndrome. Usually it is seen in females, but can also be considered in males who present with digital gangrene. And lastly, we thought about other prothrombotic states. When we have touched antiphospholipid antibody syndrome, we will also think about other prothrombotic states like protein C, proteinase deficiency, and antithrombin 3 deficiency, as they can also present with digital gangrene. So let's see what our investigations revealed.
Based on the history and examination, we conducted following investigation. His CBC showed a reduced hemoglobin of 9.7 with MCV 84.6. His TLC was raised 19.2 with neutrophilic count 65%, lymphocytic count 15%, eosinophilic count 2%. His platelet count was 516 and CRP was raised 104.3. His liver function tests were normal. His renal profile revealed a raised creatinine of 1.6 while rest of the renal function tests were normal. His viral marker, including HIV serology, were non-reactive. His iron profile was suggestive of anemia of chronic disease. His coagulation profile showed raised APTT of 33 seconds. His fasting lipid profile was normal. His autoimmune workup, including ANA, anti-dsDNA, and ENA profile, were negative with normal complement C3 and C4 level. Moving on to imaging investigation, his chest X-ray was normal. His ultrasound abdomen was normal. His echo showed mild hypertrophy of left ventricle with normal function, with final conclusion of borderline LVH and ejection fraction 61%. His ultrasound Doppler bilateral lower limb vessel show right-sided anterior tibial, posterior tibial, and dorsalis pedis having reduced monophasic reduced blood flow. Ultrasound Doppler bilateral upper limb vessel, bilateral radial, and ulnar artery showed reduced blood flow. CT angiogram of right upper limb was done at Punjab, in which a thrombus was seen along the right brachiocephalic trunk, first part of subclavian artery, distal third of ulnar artery, and distal third of radial artery. His CT chest with contrast was also done at Punjab, in which lung parenchyma showed extensive centrilobular and paraseptal lymphysematous changes, fibroattenuated bands, patchy areas of consolidation in right middle and lower lobe, suggestive of infective or inflammatory etiology. His thrombophilia workup, including antithrombin 3, protein C, and S activity, was normal. Meanwhile, his APLA workup came out to be positive with both lupus anticoagulant and anticardiolipin IgM and IgG positive. During hospitalization, our patient's lab further deteriorated with hemoglobin dropping from 9.7 to 8.1, CRP raised from 104.3 to 188.5, burn raised from 19 to 26, and creatinine jumped from 1.6 to 2.9. Meanwhile, his urine DR showed a proteinuria of +3, hematuria +2, and red cell 20 to 22. So is this catastrophic APS?
In our patient, the presence of arterial thrombosis and positive lupus anticoagulant and anticardiolipin antibody led us towards the diagnosis of antiphospholipid syndrome. In this setting, with the sudden decline in renal function, the possibility of catastrophic antiphospholipid syndrome was considered. Now, what is catastrophic APLA? Basically, it is a rare but more severe form of APLA, which presents with multi-organ failure associated with microthrombosis. Upon reviewing the literature, we came across this criteria, which consist of 4 points. Now, for the definitive diagnosis, you need to have all these 4 points to be present, whereas for probable diagnosis, you need to have at least 3. Now, focusing on the first 2 points, which suggest the evidence of involvement of 3 or more organ systems, along with the development of manifestations occurring simultaneously or in less than 1 week. In our patient, although 3 organ systems were involved, with lung involvement in around 1 year back, cutaneous findings some 25 days ago, and now this sudden renal involvement. However, this organ system was sequential rather than simultaneous, so this seems to be less likely. According to the criteria, only 1 point was positive, which was the presence of APLA antibody. Hence, catastrophic APLA seems less likely. So we were confused that are we still dealing with antiphospholipid syndrome? According to the literature, APLA can present with varied cutaneous manifestation apart from digital gangrene. It can also present with livedo reticularis, leg ulcers, pyoderma gangrenosum, etc. It can also mimic vasculitis, where it presents with painful papules, nodules, purpura, ecchymosis, and red macules. But even then, it does not present with blisters. So here we paused and we started to wonder that maybe our patient is suffering from some other entity, or APLA is coexisting with some other disease. So what could be done next for this patient?
To rule out this sudden renal involvement, nephrology department was taken on board for deranged creatinine, hematuria, and proteinuria, and they advised to get renal biopsy done. Renal biopsy was done, including both histopath and immunofluorescence. The histopath at lower magnification, the methamine silver stain revealed multiple crescent, and these cellular crescent illustrate multiple layer of parietal epithelial cells compressing onto glomerular duct. His immunofluorescence revealed a completely negative panel with final conclusion of posse-immune precentric glomerulonephritis. Since in posse-immune precentric glomerulonephritis there is no or only few immune complex deposition, and our patient had posse-immune precentric glomerulonephritis, and it is associated with ANCA-associated vasculitis. So the renal involvement could be due to microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, or granulomatosis with polyangiitis. Meanwhile, his vasculitis workup was chased, in which his C-ANCA came out to be positive but negative P-ANCA. His X-ray paranasal sinus was done, which was normal. ENT review was taken, in which nasal cavity showed no evidence of nasal polyp, nasal septal defect, or any evidence of sinusitis. His otoscopic examination was also normal.
Here we were pretty sure that our patient did not have eosinophilic granulomatosis with polyangiitis because of C-ANCA positivity and the absence of classic clinical features of asthma, allergies, nasal polyps, or eosinophilia in lab reports. But we were still unsure between granulomatosis with polyangiitis and microscopic polyangiitis because of absence of upper respiratory symptoms but presence of C-ANCA. Granulomatosis with polyangiitis presents with a triad of upper respiratory, lower respiratory, and renal symptoms with C-ANCA positivity, while microscopic polyangiitis has lower respiratory and renal involvement, it rarely presents with upper respiratory symptoms. Also, P-ANCA is commonly positive, but rarely C-ANCA can also be seen. To solve this riddle, we took the help from this 2022 EULAR criteria, in which for the diagnosis of either of these two types of vasculitis, we need to have at least 5 or more points. So our patient scored 5 points under granulomatosis with polyangiitis due to C-ANCA positivity, whereas minor scores were given for this finding under microscopic polyangiitis criteria. Also, 1 point was given for posse-immune precentric glomerulonephritis with a total score of 6. So according to this, our patient was having granulomatosis with polyangiitis.
Up till now, we have gangrene of right hand, digital tip of middle and index finger of left hand, and third toe of right foot, along with blister on both feet. APLA serology positive with final conclusion of antiphospholipid syndrome. C-ANCA positive along with posse-immune precentric glomerulonephritis with final diagnosis of granulomatosis with polyangiitis. So the dilemma was that, can these both entities coexist with each other? For that, we went for literature review. In one of the literature published in Oxford Academic showed that 21 to 51.7% of anti-neutrophilic cytoplasmic antibody-associated vasculitis patients were EPLA positive, and this proportion of EPLA positivity increased the thrombotic risk in patients with ANCA-associated vasculitis. A possible explanation is that microvascular thrombosis with subsequent increase in vascular permeability facilitate perivascular IgG and complement deposition, leading to development of capillaritis. In other literature suggested the patient with the similar case presentation to our patient shows that a male patient presenting with distal digital gangrene and inflammatory arthralgia having high titers of anti-proteinase 3 and antiphospholipid antibodies, further solidifying that these two entities can coexist with each other. So our final diagnosis is granulomatosis with polyangiitis coexisting with antiphospholipid syndrome. For the management, internal medicine department was taken on board, and for vasculitis, they gave injection methylprednisolone pulse for 3 days and then switched the patient to tablet delta cortel 1 mg per kg and injection cyclophosphamide 1 gram pulse. For EPLA, they advised to give patient injection enoxaparin 60 mg sub-Q OD according to the creatinine clearance. On follow-up visit, our patient's blister completely resolved. and gangrene has remained static and has not progressed beyond. This case has been published by our department in Pakistan Journal of Medicine and Dentistry also. So my take-home message is that this case reminds us that not all the patients follow the textbook. When the feature overlap a broad and evolving clinical lens, help us navigate uncertainties with clarity and care. Thank you.
This was a very challenging and a thought-provoking case for us. Antiphospholipid antibody syndrome is rare in males, but one must consider this differential diagnosis when patient presents with digital gangrene, regardless of gender. Granulomatosis with polyangiitis has varied clinical presentations, and it can present in males and females equally. It can also present with digital gangrene and blisters along with systemic symptoms. However, the coexistence with antiphospholipid syndrome was unexpected. Here I want to point out that thrombosis can also occur in granulomatosis with polyangiitis, but it is typically venous rather than arterial. In contrast, antiphospholipid syndrome can present with both arterial and venous thrombosis, and in males it usually presents with arterial thrombosis like this was in our case. So yes, our patient had mixed clinical features and conflicting lab reports, which made the diagnosis far from being straightforward. In such scenarios, one should not rest with incomplete answers, but rather engage in continuous reading, critical thinking, and also collaboration to help these patients. So this was all from case number 1. Thank you very much.
Thank you so much, Dr. Ikta and Dr. Neha, for sharing such an interesting and amazing case with all of us. Now proceeding towards our second clinical case that will be discussed by Dr. Pashmala under the supervision of Madam Humaira Tala. So I would like to invite Dr. Pashmala on the podium.
Welcome everyone. My name is Dr. Pushpmala, postgraduate trainee dermatology at Civil Hospital Karachi. Today I'm going to present an interesting case with you all. So starting with the history. A 25-year-old male patient, unmarried, resident of Karachi, shopkeeper by occupation, admitted via OPD on 10th of October 2024. With the complaint of generalized reddish rash on whole body since childhood and non-healing ulcer on the both feet for last 10 years. According to my patient, he has generalized skin rash on the body, which started during early childhood. The rash is reddish to purple in color and first appeared on the face, palm, and soles. Later on, it progressed rapidly to involve the entire trunk and extremities within a period of 3 to 4 months. It is neither itchy nor painful, not associated with any constitutional symptoms like fever, headache, or joint pain. He also complained of non-healing ulcer on the dorsum of both feet for last 10 years. Initially, lesion started on the dorsum of right foot is a small pea-sized pustule that ruptured spontaneously to form a small ulcer, which gradually increased in size with time and was associated with mild pain and yellowish purulent discharge occasionally. He also got ulcer on the left foot in a similar way within a year. He consulted multiple doctors in his locality and was prescribed oral and topical medication, but there was no improvement. There is no history of trauma, numbness, paresthesia, or leg pain upon walking. He denied photosensitivity, oral ulcers, joint pain, or Raynaud's phenomenon. Systemic review was unremarkable. And past medical history, our patient has history of admission at Tertiary Care Hospital of Karachi 1 year back for the complaint of one episode of fit, followed by loss of consciousness. No history of any blood transfusion, while surgical history was insignificant. In family history, Patient is a product of consanguineous marriage, having 4 siblings, 2 brothers and 2 sisters. All family members are healthy and alive. No history of any heredity and acquired illness in family. Allergic history was not significant. And in developmental history, patient achieved the developmental milestone timely and has a normal IQ. In drug history, he has been prescribed with topical and oral medication, but patient doesn't know the names. And vaccination history is positive for the BCG vaccine. Personal history, his sleep was normal, appetite was normal, bowel habits were regular, weight loss was not present, and patient was addicted to betel nuts. Socioeconomically, he belongs to lower middle class family, lives in a well ventilated house, and there is no exposure to birds, pets, and birds. On examination, a young male patient of average height and build, sitting comfortably, well oriented to time, place, and person. At the time of presentation, he was vitally stable with a blood pressure of 120 by 80 millimeter of mercury, pulse rate of 84 beats per minute, respiratory rate of 12 beats per minute, and temperature was 98 Fahrenheit. Some vitals were not present, JVP was not raised, lymph nodes and thyroid gland were not palpable. On cutaneous examination, generalized erythema on the face, trunk, and extremities were more marked on palm and soles. On closer examination, there are numerous telangiectasias present all over the body and extensive confluent sheets with the area of sparing in between. All above mentioned areas were fully blanchable on performing diascopy. No atrophy, purpura, or depigmentation noted. On the examination of oral cavity, erythema and telangiectasias were present on oral mucosa, while poor oral hygiene was noted. In ocular examination, no ocular telangiectasias noticed on ophthalmological examination. In addition, he had few well-defined, irregularly shaped, dry crusted ulcer on the dorsum of both feet. The largest one was present on the right foot, measuring 4 into 2 centimeter in size, with irregular margins, sloping edges, and thick yellowish crust tightly adherent to the underlying base of the ulcer, surrounded by hyperpigmented rim of skin. No shiny areas of skin with hair loss present. These are the picture of the patient, which shows diffuse erythema of the hands and forearms. The first picture shows confluent sheet of telangiectasias on the back with areas of sparing, and the second picture shows non-confluent sheet of telangiectasias on the abdomen and chest. This is the closer view of anterior chest and anterior neck, which shows non-confluent sheet of generalized telangiectasias. This picture showing the oral mucosa with telangiectasias on the lower lip. This is the diascopy test performed on the forehead and forearm, which shows blanchable erythema. These are the pictures of dry, crusted, irregularly shaped ulcer present on both dorsum of the feet. Cardiovascular examination along with peripheral pulses were unremarkable. Respiratory examination, abdominal examination, and CNS examination all were within normal limit. Case summary. A 25-year-old male patient with no known comorbids present with diffuse reddish to purple rash on whole body since early childhood, non-healing ulcers on the dorsum of feet bilaterally for 10 years. He had past history of hospital admission due to one episode of fit, followed by loss of consciousness 1 year back. On examination, there is generalized erythema due to telangiectasias involving whole body and oral mucosa. On diascopy test, rash is fully blanchable. Well-defined, irregularly shaped, dry crusted ulcer present on dorsum of both feet, the largest one measuring 4 into 2 centimeter over the dorsum of right foot with overlying yellowish crusting tightly adherent to the floor. I would like to invite my supervisor, Dr. Humaira Talat, for further discussion on the differential diagnosis.
Assalamu alaikum everyone, and today we are here with another challenging case. The first one already discussed by Dr. Ikta and Dr. Neha Rana. This case was challenging from the beginning till the end. Initially, the patient presented with diffuse telangiectasias. So with diffuse telangiectasias, the differential we made are the hereditary hemorrhagic telangiectasia. As patient has presented with telangiectasias all over the skin, the telangiectasias were diffuse. Somewhere those telangiectasias were confluent, and these were also present on the mucosa. However, there were no telangiectasias noted on the sclera. and patient has no neurological symptoms. And due to the presence of these telangiectasias, and patient had episode of fit 1 year ago, that's why we kept hereditary hemorrhagic telangiectasias on the top. Later on, generalized essential telangiectasia is another variant in which the telangiectasias started later in the life, and the telangiectasias are diffuse, somewhere they are confluent, but there is no systemic involvement. Then comes the benign hereditary telangiectasia, that is another variant, and it is also like hereditary hemorrhagic autosomal dominant. But in this case, it also the lesions started earlier in childhood, and later on the lesions progressed. And again, there are occasional cases in which nasal bleeding has been reported. However, in this benign hereditary telangiectasias, there is no systemic involvement. We have kept ataxia telangiectasia down the list because patient had no neurological symptoms, and obviously there were no telangiectasias on this sclera. With this, we will proceed with the investigations. I would like to invite again Dr. Pashmala for the extensive workup that we have done for this case.
We went for some routine investigations. So his CBC was normal with the HP of 12 milligram per deciliter, TLC of 6.2, and platelet count was 334,000. Patient CSR was mildly raised of 20 millimeter per hour, while CRP was normal with 2.1 milligram per liter. His renal function tests with calcium, magnesium, and phosphorus all were normal. Liver function tests along with protein AG ratio was within normal limit. Coagulation profile was within normal limit. His viral marker, including surface antigen, anti-HCV, and HIV serology, all were down-reactive. Autoimmune profile, including ANA, AMA, asthma, and ENA profile, all came out to be negative. To rule out the GI bleeding, we went for the stool for occult blood, and it came out to be negative. In imaging studies, his chest X-ray was normal. Ultrasound abdomen was normal. Ultrasound Doppler of abdomen showed normal Doppler study of liver and spleen. Ultrasound Doppler of lower limb showed no arterial insufficiency in bilateral lower limb arteries and no evidence of deep venous thrombosis. Echocardiography showed normal sized left ventricle with normal systolic function and ejection fraction of 60%. His electroencephalogram was done. It showed no epileptiform activity or side-to-side asymmetry, and it came out to be normal. To rule out AV malformation in the brain, we went for the MRI, MRA, and MRV of brain with contrast, and it showed hypoplastic A1 segment of right anterior cerebral artery, which was a normal variant, while rest of the MRA and MRASV study came out to be unremarkable. CT chest and abdomen arteriogram was done, which shows no evidence of atriovenous malformation. So we want to short down our list of differential diagnosis on the basis of the extensive workup.
Till now, along with the routine investigations, we extensively worked this case, and initially we were sure that we are dealing with hereditary hemorrhagic telangiectasias. Why? Because as we have already discussed, patient had diffuse telangiectasia, but the thing that was against HHT was patient had no family history. His parents are quite normal, siblings are all normal, and again, patient had no history of typical nosebleed that we that is given in literature in cases of HHT. The extensive workup, including the MRI, MRA, MRV, and chest arteriogram, that was challenging to carry out also, because we being part of Civil Hospital Karachi, and you all must know that it is too difficult to carry out all these investigations, and even to make the patient and the attendants understand that why we are going to do these investigations. Because our patient used to say, मैं तो बिल्कुल ठीक हूँ, आप ये टेस्ट क्यों करा रहे हैं? मैं बिल्कुल सही हूँ, बस सिवाय इस स्किन की खराबी के मुझे कोई भी मसला नहीं है, तो आप इतने ज्यादा टेस्ट क्यों कराते हैं? To make him understand, it was difficult and challenging. And for this, we carried out this MRI, MRA, MRV, and then later on discussions with the radiology department all turned out to be normal. So after this extensive workup, HST was ruled out. And ataxia telangiectasia, because of the presentation was not there, so therefore we have ruled out ataxia in the beginning, but hereditary hemorrhagic telangiectasia was also ruled out. Then we were left with generalized essential and benign hereditary telangiectasia. There are only a minimal difference if you look all these type of diseases like HHT get generalized essential and benign hereditary telangiectasia. So we will be discussing the salient features of all these three types one by one. And I would like to invite Dr. Pashmala to discuss the salient features of all the three types of diseases.
Let's discuss the characteristic of all remaining three differential diagnoses. The mode of inheritance in HHT is autosomal dominant and in BHT is again autosomal dominant, but generalized essential telangiectasia is a non-inherited disorder. The onset of the HHT is in early second decade, while BHT can be present at birth and in childhood, and generalized essential telangiectasia has a late onset in fourth decade. The course of HHT is lethal, while BHT and generalized essential telangiectasia has a non-lethal course. There is skin, mucosal, and visceral telangiectasias in HHT, but in BHT, skin and oral mucosa are involved. But in generalized essential telangiectasia, skin is involved, but mucosa may or may not be involved. AV malformations are found in HHT, while there are no AV malformation in the remaining two. There is increased risk of bleeding in hereditary hemorrhagic telangiectasias and occasional risk of bleeding in benign hereditary telangiectasias, and generalized essential telangiectasias carries no risk of bleeding. And the diagnostic criteria of HHT include epistaxis that can be spontaneous and recurrent, family history with the first degree relative, telangiectasias at characteristic sites like lips, oral cavity, fingers, and nose, and visceral lesions like gastrointestinal telangiectasias with or without bleeding, pulmonary, hepatic, cerebral, and spinal AV malformation. For the definitive diagnosis of HHT, three criteria should be present from the above-mentioned criteria, and for the suspected or possible diagnosis, two criteria should be present. But as in our patient, there was only telangiectasia, so HHT is unlikely in our patient. So we were left with generalized essential telangiectasia and benign hereditary telangiectasias.
If patient has AV malformations in different part of the body like brain, then they present with those symptoms. If it is present in the brain, then patient can present with early stroke. If it is present in the lung, then they can present with the shortness of breath. If it is in GI, then the stool for occult blood should be positive. And we went for the Doppler ultrasound of the liver because at times liver has large AV malformations. And according to one study of when they found that out of 100%, 70% AV malformations in the lungs were secondary to HHT. So no such finding was present in our patient. That's why after that extensive workup and extensive discussion, we ruled out HHT. Now we are left with benign hereditary and generalized essential telangiectasias. Here you can see the features are very much mimicking to each other, but benign hereditary telangiectasias are autosomal dominant, and generalized essential telangiectasias started later in the life, and therefore uh, in our patient, the lesions started in childhood. Therefore, the point that favors benign hereditary telangiectasias is the early onset, and the lesions were present in both the cases. Skin and oral mucosa is involved in both the cases, benign hereditary as well as in generalized essential telangiectasias. So, in both the cases, there are no AV malformation. As in our patient, there was no such finding and no symptoms and signs that, or the extensive workup ruled out AV malformation. So, we were thinking, are we dealing with benign hereditary or we are dealing with generalized essential telangiectasias? We went for the biopsy report. Let's discuss further.
Patient skin biopsy was done, which shows intact epidermis and dilated venules, capillaries, and arterioles with thickened wall in the superficial dermis. And the conclusion was findings were consistent with telangiectasias. However, clinical correlation was advised. So as the patient's characteristics were matching with BHT more than generalized essential telangiectasia, so we made the final diagnosis of benign hereditary telangiectasia. For the management, patient was counseled regarding the benign nature of the disease apart from cosmetic disfigurement and no definitive management of the condition. In the literature review, we found that benign hereditary telangiectasia was first mentioned in medical literature in 1971 by researcher Wells and Dowling, who published a paper on the topic in British Journal of Dermatology. BHT is a rare skin disease characterized by widespread cutaneous telangiectasias, and it is differentiated from the HHT by lack of bleeding and no systemic involvement. As in our patient, there was no systemic involvement. This is a case report that was taken from Turkish Journal of Pediatrics, which presented two 13 and 16-year-old girls with telangiectasia on the outer side of the labia mucosa and telangiectasia on sun-exposed areas like face, back of the hands, and forearm. Both of the patients were otherwise in good health and no hemorrhagic episode or systemic disorder. None of the both family member had any history of similar lesion or hemorrhagic episode. As we know, benign hereditary telangiectasia is an autosomal dominant inherited disorder. However, it has been described in the cases without positive family history because in our patient there was no family history, and reference has been taken from Rook's textbook of dermatology. And the last, we have brought a small scenario of a young girl that was presented in our dermatology OPD with difficulty in walking since early age and history of recurrent infections. And bilateral ocular telangiectasias are visible in the pictures. Her diagnosis was ataxia telangiectasia, and the first cardinal sign of the disease is ataxia. And the last, our take-home message is telangiectasia is a common finding in the daily clinical practice. However, when present in large number, it warrants consideration of previously discussed disease and necessitates ruling out systemic involvement. Thank you.
Thank you, Dr. Pashmala. In the end, I would like to thank our trainees because they worked hard to carry out all the investigations in both these cases. In the case of that granulomatosis with APLA and in hereditary hemorrhagic or the differential we made of benign hereditary telangiectasia, the extensive workup carried out and it took months and I think 2 to 3 months, and it was not easy to carry out all the investigations. So I would like to appreciate and would like to congratulate my trainees first, then my departmental fellows and all my colleagues. So thank you very much. With this, this was end from our part. If there are any questions from anyone, then you can ask the questions or you can comment on both the cases.
Thank you so much, Dr. Pashmala and Madam Humera, for sharing such an amazing and wonderful presentation with all of us. So now that we are done with the cases, let's proceed with question answer sessions. So the audience can join us in the chat box and ask the questions virtually. They can ask us virtually, and if anyone want to. Okay. Is there any correlation of BST with development of ulcers in future?
Yes, because this case was more कि आप करीब से इसको देखते हैं. दूर से telangiectasias are हमने कोशिश तो करी है कि वो हाईलाइट करें, बट ये करीब से देखने वाला केस. इसमें आप ये देखेंगे when telangiectasias are so diffuse and patient can develop ulcers at any site of the body. And he had developed these ulcers 10 years back, and we tried our best to look up for any other cause of the ulcer, but we could not find any other cause. So the cause is HST, and yes, patient can develop ulcers in future. He has to save himself from trauma as well, and we have counseled him well.
Okay, we are. You can ask the questions directly and virtually if anyone wants to. Any comment from the audience?
Someone asking that if this could be the Ruthven-Thompson syndrome. No, this is not the presentation of Ruthven-Thompson. At least some bony deformity should be there. There was no poikiloderma, there was no photosensitivity. So he was not a case of Ruthven-Thompson syndrome.
What is the prognosis of first case?
The prognosis of this, because the patient was suffering from two very lethal diseases, so the prognosis is not very good in such cases.
Treatment options of regarding what case, first or the second one? Kindly elaborate. Treatment options. They didn't mention the case because SST mentioned.
In the first case, we have already discussed the treatment options because we have to carry the two diseases, APLA and vaginous. However, in HST, the treatment options are very limited. If the telangiectasias are limited, then you can go for the laser treatment. But he had diffuse telangiectasias all over his body, so it was difficult to carry out the lasers as well.
Is there anyone who wants to join and comment on the cases? On air? Okay. Is there a role of beta blockers in HST?
The modified treatment of HST is baclizumab and thalidomide. That can affect the angiogenesis of the vessels, and to some extent it can improve the lesions, but this is also experimental. However, there is no other treatment.
We would appreciate if anyone wants to join live and share their comments.
Assalamu alaikum. Dr. Humera, heartiest congratulations for this very rare case presentation. And I think I have never seen this case in my life, or it may be missed by me. I think this type of the activities are very, very helpful to the even the most senior dermatologists, because this is the, you can say, the essential part of the teaching hospital, where we miss so many
Thank you, Dr.
things in
Javed
our
Neman.
regular OPDs. So, heartiest congratulations.
Thank you, sir.
For this rare case presentation. I hope
Now I would like to invite Dr. Rima Mirza for a vote of thanks. Ma'am, kindly come on the podium.
In the end, on behalf of Dermatology Department, Civil Hospital, Karachi, I would like to thank all the listeners for sparing their time to participate in this activity. And also special thanks to our presenters, Dr. Pashmala, Dr. Ikta, and their supervisors, Dr. Humera and Neha. Also, I would like to appreciate the efforts of Brook Pharma, especially Mr. Yasir, for the arrangements of this program. With this, we end this meeting. Thank you.